Welcome back, and this is video 2 in my complete IUI series. In video 1, we covered what is IUI, who it is right for, and the honest success rates. If you haven't watched that first, I'd suggest starting there. The link is in the description. In this video, we go inside the IUI cycle itself. Every step of the stimulation, every scan, the trigger injection, the procedure, and everything that happens on the day of IUI. So many questions and each one answered fully. Let's begin. Question 1. Natural cycle IUI versus stimulated IUI. Which gives better success rates? A natural cycle IUI means no medication, and we track your natural ovulation and inseminate around it. No tablets, no injections. It sounds appealing, less interference with your body, but the evidence is very clear on this. A Cochrane systemic review found that stimulated IUI procedures meaningfully give you higher cumulative live births compared to a natural cycle. If the chance of a live birth with natural cycle IUI is about maybe 6%, it rises to somewhere between 14 to 15% with stimulation. That's a real difference. Why? For two reasons. First, stimulation gives you more eggs working simultaneously. One egg means one chance. 2 or 3 eggs mean multiple parallel chances in the same cycle. Secondly, stimulation gives us control over timing. In a natural cycle, ovulation is harder to predict precisely. With stimulation and a trigger injection, we know exactly when ovulation is going to happen and can schedule the insemination exactly around it. Natural cycle IUI has a role in very specific situations. Patients who respond poorly to medications or where the stimulation carries very unusual risk. But as a routine approach for most patients, stimulated IUI is the better performing option by an absolutely clear margin. Question 2. Why do doctors aim for only 2 to 3 follicles in IUI and not more? You see, every follicle represents one egg, one independent chance at fertilization that cycle. So, one follicle gives you roughly about 5 to 6% success. 2 to 3 follicles takes that to roughly about 15%. That's real, meaningful improvement. Each additional follicle in that range adds to the probability. But beyond 3, the equation changes. Success doesn't keep rising proportionately. What does rise sharply is the risk of multiple pregnancy, twins, triplets, or even higher. And multiple pregnancy is not a bonus outcome in fertility medicine. It's a complication. Twin pregnancies carry significantly higher rates of premature birth, low birth weight, gestational diabetes, blood pressure, and of course, a cesarean section delivery. Triplets and above carry risks that I would describe genuinely as dangerous for both the mother and the baby. So when I aim for 2 to 3 follicles, I'm not being cautious. I'm targeting the clinical, very sweet spot where success is meaningfully improved but safety is still preserved. More than 3 and the risk balance tips very unfavorably. A very large Dutch multicentric study confirmed that a successful stimulation outcome defined as 2 to 3 follicles above 15 millimeters is the target, and that both under response and over response will cost you. 2 to 3 is not an arbitrary number. It is evidence-based optimization. Question 3. Letrozole versus clomiphene versus injections for IUI. What is the difference? This is one of the most practically important questions in IUI, and the answer is more nuanced than most patients and many clinicians appreciate. Letrozole, taken as tablets for 5 days early in the cycle, is now the preferred first-line agent in most IUI protocols, particularly in PCOS and endometriosis patients. It works by temporarily reducing the estrogen, which prompts the pituitary in the brain to release more FSH and stimulate the follicle growth. Critically, letrozole has minimal anti-estrogenic effect on the uterine lining, meaning it stimulates the follicles without compromising the lining. It also tends to produce a more controlled response with lower multiple pregnancy rates than when injections are used. Clomiphene citrate or Clomid, also tablets, also widely used, work differently. It blocks the estrogen receptors in the brain prompting the FSH release. It's definitely very effective at stimulating ovulation, but it also has an anti-estrogenic effect on the uterine lining and the cervical mucus. In some patients, it makes the lining of the uterus very thin, which can reduce the implantation potential. That is why clomiphene, while still useful, has largely been replaced by letrozole as the preferred oral agent. Gonadotropin injections are injectable hormones that directly stimulate the ovary. They are more powerful than the oral agents and produce higher live birth rates. A 2022 individual data analysis covered 2,400 patients, confirming that injections gave approximately 30% higher live birth rates compared to simply giving clomiphene. But that higher efficacy comes with higher multiple pregnancy risks and significantly higher cost. The practical framework: letrozole is usually the starting point. Effective, well tolerated, affordable, and safer in terms of lining quality. If response is inadequate or we want a better response, we add the gonadotropins. Clomiphene remains useful in resource-limited settings or where letrozole isn't available. The key insight from current evidence is that with low-dose gonadotropins and strict monitoring and cancellation criteria, the safety gap between injections and the oral agents narrows considerably. The drug matters less than how you use the drug. What is the ideal follicle size before the IUI trigger injection? The standard target in most clinical protocols is a leading follicle of 18 to 22 millimeters before administering the trigger injection. This size range corresponds to a follicular maturity, the stage at which the egg inside is most likely to be mature and ready for fertilization. A follicle below 18 mm may contain an immature egg. A follicle that has been over-mature for some time, 24 millimeters or beyond in some cases, carries a different risk. The lining assessment at the same time, the scans, matter equally. We want to see an endometrial thickness or lining of the womb of at least 7 to 8 millimeters with a triple line pattern on ultrasound, which indicates proper lining development. A follicle at the right size with a thin or poorly developed lining is not an ideal situation to proceed with. Timing the trigger precisely at the right follicle size is one of the key decisions in IUI. Too early and the egg is immature. Waiting too long risks the follicle collapsing by itself, that is, ovulating before the trigger, which throws off the insemination timing completely. That is why several serial monitoring scans aren't just bureaucracy. They are how we catch the right window. Question 5. When do we doctors cancel an IUI cycle? This is one of the most important clinical decisions in IUI, and it's one that a good clinic will always take seriously. Typical cancellation criteria when too many follicles develop would be more than 3 dominant follicles in most patients. In younger patients, some centers use a threshold of even 2 or 3. In older patients with lower baseline risk of multiple pregnancy, maybe the threshold can be slightly more permissive, but 3 remains the general standard. When a cycle is cancelled for this particular reason, 2 options are usually available. The cycle can be abandoned entirely and the patient waits for the next menstrual cycle, or that stimulation can be converted to an IVF cycle, where we retrieve the eggs, fertilize them in the lab, and transfer a controlled number of embryos. Cycle conversion to IVF is actually an important option in this situation, one that the patient should be aware of and discuss with their clinic before starting treatment. Why is cancellation the right treatment and not just a setback? Because a triplet or a higher order pregnancy carries risk for the mother and the baby that is not acceptable compared to the risk of infertility. As I've said earlier, premature labor, neonatal complications, long-term developmental issues, these are outcomes that a responsible clinician must weigh seriously. Good clinics are judged not just by the pregnancies they achieve, but by the cycles they have the discipline to cancel. This is an area where clinical judgment and ethics interact, and I want my patients to understand why I make that call when I do. Can IUI cause ovarian hyperstimulation syndrome? OHSS, or ovarian hyperstimulation syndrome, is primarily a concern in IVF, where higher doses of injections are being used to retrieve multiple eggs. In IUI, with milder stimulation protocols, very significant OHSS is very uncommon, but it is not impossible. particularly in certain patient profiles. So risk is higher in PCOS patients who can respond very briefly to even small doses of stimulation. Patients with very high antral follicle count, many small resting follicles who are at the risk of over-responding. Cycles where injections are used rather than oral agents, and that too at a higher dosage. Mild OHSS, bloating, some discomfort, mild abdominal swelling can occur even in IUI cycles and is manageable. Moderate to severe OHSS in IUI is very rare with properly dosed, properly monitored protocols. Letrozole by itself carries a very low OHSS risk. The safety mechanism is the monitoring. When the ovarian response is excessive, too many follicles develop rapidly, the estradiol level rises, we cancel the cycle before the trigger. No trigger means no ovulation of multiple eggs simultaneously and significantly reduces the OHSS risk. This is another reason that monitoring is not optional. It's a safety net. Next question. What do we check at every IUI scan? Every scan is a clinical assessment, not just a count of follicles. So here is what we evaluate. Follicle count and size. How many follicles are developing in each ovary? What size each one is and which is the leading follicle. A follicle grows about 1 to 2 millimeters per day. So the scan interval and the size together tell me when to expect maturity. We also look at the follicle growth rate. If the follicle is too slow, I may need to adjust the stimulation dose. If it's going too fast or there are more than expected, the cycle may need cancellation. Then we check the uterine lining thickness and pattern. The lining should be growing parallel with the follicles, driven by estrogen from the developing follicles. A triple line pattern on ultrasound is what we want. Thin or poorly developing lining, particularly with clomiphene, may alter the clinical plan. We also sometimes check the ovarian volume and appearance. If the ovaries are already enlarged or showing signs of over-response very early during stimulation, that's a safety flag. Any unexpected findings, a functional cyst from the previous cycle, a follicle that didn't ovulate last time, fluid in the pelvis, these can all change my management. Each scan drives the next clinical decision. Nothing is just observation. What is the trigger injection in IUI? The trigger injection is one of the most important steps in an IUI cycle. Its job is to complete the final stages of egg maturation, called the LH surge, and to tell the body precisely when to ovulate. In a natural cycle, the brain releases the surge of LH hormones by itself, which triggers ovulation within 36 to 40 hours. The problem is that this natural surge is very difficult to predict precisely. It can happen earlier or later than expected and throws off the timing of the insemination. The trigger injection, usually an HCG injection, replaces or supplements that natural LH surge. And because we give it at a time we choose, we now know exactly when ovulation may occur. And that lets us schedule the IUI at the optimal time in that window. The two most commonly used triggers are HCG, which is the standard trigger, widely used and reliable, the same hormone that pregnancy tests detect, which is why testing too early after IUI gives misleading results. One can also use a GnRH agonist trigger used instead of HCG in PCOS patients or anyone at the risk of OHSS. It produces a more natural pattern LH surge from the brain and carries a lower OHSS risk. A 2025 Cochrane review found no clear evidence of a distinct difference in live birth rates between the HCG and the GnRH agonist triggers. The choice is often guided by the patient's risk profile. Without a trigger injection, timing the insemination correctly becomes substantially less reliable. How is the timing of the IUI decided after the HCG trigger? After the trigger injection, ovulation occurs within a predictable window. Most commonly, 36 to 40 hours for HCG, slightly earlier for GnRH agonist triggers. The IUI is timed to fall within that ovulation window, with the intent that motile sperms are present inside the fallopian tube when the egg is released. Sperm has an important advantage here. Well prepared, motile sperms can survive inside the female reproductive tract for 24 to 72 hours. The egg, by contrast, has a much shorter viability window, approximately 12 to 24 hours after ovulation. This biology is why we want the sperms in position before ovulation and not after. Sperms waiting for the egg is more reliable than the egg waiting for the sperm. The practical scheduling is that most clinics trigger in the evening and schedule the IUI approximately 36 hours later, often the morning after the following day. This sounds really sensible for both clinical and patient scheduling reasons. A 2023 RCT in human reproduction showed that the time interval between semen processing and the insemination also affects outcome, with longer preparation time allowing better sperm optimization. The key message here: there is no single magic number, and rushing unnecessarily is not going to be advantageous. Each clinic should have their well-calibrated protocol for their specific lab and workflow. What is the best timing for IUI after trigger? 24 hours, 36 hours, 40 hours. 36 hours is the most widely used clinical standard, and for good practical reasons. It falls squarely within the expected ovulation window for HCG trigger. And to be very honest, this is what the evidence is showing. A 2025 Cochrane review found insufficient evidence to determine whether any specific time interval is definitely superior to another. The comparisons between 0 to 33 hours, 34 to 40 hours, and beyond 40 hours were all too imprecise to draw any firm conclusions. What does this mean practically? 36 hours is a reasonable, evidence-informed standard. But obsessing over whether it's 35 hours and 45 minutes or whether it's 36 hours and 15 minutes is not clinically meaningful. What matters far more is whether the follicle was genuinely mature when the trigger was given, whether the sperm preparation was good, whether the overall cycle was well designed. 36 hours is a sensible target. It is not a magic number. The quality of everything before that moment matters more than the precise timing of the insemination itself. What happens if you ovulate before the IUI procedure? Now, honestly, this does happen occasionally, even in well-monitored cycles. The follicle ruptures before the planned insemination timing. The egg has already been released. What we do in this situation depends on when we find out. If we detect on the IUI day scan that the ovulation has already occurred, the follicle has collapsed, there's free fluid in the pelvis, we have two options. We may still proceed with the IUI if the timing suggests that the egg may still be viable, or if we can determine that ovulation happened within the last few hours. Given that sperm placed inside the uterus can survive for many hours, there's still a window. We may convert the cycle to a timed intercourse and ask the couple to have sex immediately. In some cases, particularly if the scan suggests ovulation happened the previous night and significant time has passed, we may advise that this cycle is unlikely to be effective and plan the next one differently. Early ovulation before the trigger is a different issue. It means the monitoring caught the LH surge before we intended to trigger. This is why some clinics check urinary or serum LH along ultrasound so that a spontaneous surge does not catch them off guard. The best way to handle premature ovulation is to prevent it through good monitoring. Once it happens, the options are honestly limited. Single IUI versus double IUI in the same cycle. Does it make any difference? This is a very common question, and the evidence has a very clear answer. A Cochrane systematic review directly compared double IUI, that is 2 inseminations in the same cycle, typically 12 to 24 hours apart, versus single IUI, found no clear evidence that double IUI supports live birth rates. The odds ratio was 1.15, meaning that there is a small numerical trend towards benefit, but this did not reach statistical significance and the evidence was not of that good quality. The clinical pregnancy rate, however, did show a possible moderate benefit. So what is the practical conclusion? For most patients, a single well-timed IUI is adequate. It does not need to be repeated the following day. But what we do in our clinic is, when we are making a lot of follicles, it makes sense to have more sperms inside the uterine cavity, and sometimes catching the ovulation at the right time also becomes a little difficult. Then what we do is give a trigger, do one IUI before rupture, then document the rupture and do one IUI after the rupture. That makes us catch the egg also more effectively, and that also ensures that more number of sperms are present per egg, thereby improving the chances of fertilization and a pregnancy. Can sex before or after IUI affect the chances of success? This question gets more anxious attention than it deserves. Let me give you a clear, practical answer. Sex before the IUI does not reduce success. There is no evidence that having intercourse in the days before the IUI procedure or even on the morning of IUI diminishes the result of the insemination. In fact, if at all, it's only going to make the success rates better. Sex after IUI on the same day or the day after may actually also moderately be beneficial. So intercourse places additional sperms naturally in the reproductive tract, providing a second wave of exposure around the time the egg is going to get released. Some clinicians, like me, actively encourage this. The one thing that matters regarding the timing of ejaculation is the abstinence period, meaning how long before the IUI did you actually maintain abstinence in terms of sex or masturbation, and that ideally should not be more than 2 to 3 days. Beyond that, intimacy during the cycle is not a risk. Don't avoid it. So the broader message is the IUI cycle should not turn your relationship into a scheduled, anxious, medicalized experience. Normal intimacy during treatment is not just acceptable, for most couples, it is actually healthy and beneficial. How is sperm inserted during the IUI procedure? Once the lab has processed the sperm, a procedure I'll cover fully in video 3, the prepared sample is drawn into a thin, flexible syringe connected to a soft catheter. This catheter is typically about the width of a thick thread. On the procedure table, the patient lies in the same position as a routine internal examination. An instrument called the speculum is gently placed inside to visualize the mouth of the womb or the cervix, exactly like in a pap smear. The catheter is then carefully passed through the opening of the mouth of the womb, the cervical os, and advanced into the uterine cavity. Once correctly positioned inside the uterus, the prepared sperm is very slowly and gently left there. The whole injection takes about 30 seconds. The catheter is then gently withdrawn, the speculum or the metallic instrument is removed, the procedure is completed. No cuts, no stitches, no anesthesia, no surgical preparation. The sperm is now inside the uterus, approximately at the level where the fallopian tubes enter, and the motile fraction immediately begins moving towards the fallopian tubes. Everything that determines whether the cycle succeeds was decided in the days before the moment. The stimulation, the monitoring, the sperm preparation, the timing. The procedure by itself, honestly, is also important, but it is only a culmination of everything that has been done well before it. Can you drive home and go to work after an IUI procedure? Yes, absolutely, on both counts. IUI is performed without any sedation or anesthesia. You're absolutely fully alert throughout the procedure. Your reaction time and judgments are completely unaffected. There is no medical reason you cannot drive home yourself. Going to work the same day is also entirely reasonable, although mentally I would say take rest for that day. Most patients who have an IUI usually go back to their work the very next day. The procedure only takes a few minutes. The required rest is minimal. Most of the visit time is taken up by the semen processing, which is done in the lab while you wait. The only situation where I'd suggest maybe resting for a day or two is when you're experiencing significant cramping or you've had a physically or an emotionally challenging cycle. But that's honestly for personal comfort, not a medical necessity. Normal life can resume immediately. Should the IUI procedure be done under ultrasound guidance? In most routine cases, no. Ultrasound guidance is not standard for routine IUIs, and the evidence does not show a consistent benefit of ultrasound guided over standard IUI in terms of pregnancy rates. You see, an IUI procedure is something an experienced clinician does very efficiently and accurately without requiring an ultrasound guidance or confirmation. Where the ultrasound guidance adds value is where the mouth of the womb is a little difficult, one which is kind of stenosed or closed, or the angle is actually a little different, or has been previously altered by surgery, and then under ultrasound guidance it is easier to place the catheter inside the uterus. Repeated IUI failures where the catheter positioning has been questioned is also one reason for using the ultrasound. In these situations, watching the catheter in real time on ultrasound allows more precise placement and can improve the procedure. In a straightforward patient with a normal uterus, an accessible mouth of the womb, a confident, gentle, experienced clinician performing the procedure without ultrasound will achieve the same results. The most important factor in IUI procedure success is not the equipment used. It is the clinical skill of the person performing it. And that is video 2. Every question about stimulation, monitoring, the trigger injection, and the procedure day. We now move on to video 3, which focuses entirely on the sperm side. Post-wash sperm count, DNA fragmentation, abstinence, home collection, everything the male partner needs to understand before an IUI cycle. It's one of the most under-discussed topics in IUI, and it matters more than people realize. Video 4 will cover the 2-week wait. What is genuinely happening? What symptoms actually mean? And the emotional reality of that period. If you're in Kolkata and want to discuss your own situation, consultation details are mentioned in the description. Thank you for watching.